Welcome to 988 is here. How to align efforts and leverage America's new hotline to prevent overdose. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the PHI Center for Health, Leadership, and Impact. It is time to meet the moderator of today's event, Brooke Brigance. Brooke currently serves as the Deputy Director for the Faces for the Future Coalition and is the Program Director for the Cypress Resilience Project, both these projects of the Public Health Institute. She's a certified grief recovery specialist, a certified mental health first aid instructor, and a certified trainer in trauma-informed systems and practice. Welcome back, Brooke.
Thank you, Marlene. It's lovely to be here. I am excited to talk about 988 and to think about how some emerging best practices in 988 might be leveraged to support the work that everyone's doing to prevent overdose. And start sharing my screen and making sure that we're getting this PowerPoint going. A couple of different things. As you were instructed before, the Q&A is open. Please make sure to go ahead and use that as you see fit. Also, I monitor chat. I train lots and lots of folks, so I'm constantly monitoring the chat as well. And feel free, you can use that too. So the very first thing I want to do is just sort of talk about, making sure that we all feel sort of supported during this conversation. I know that even with, we're wearing our professional hats here, maybe we've had to call 911 to check on someone before, or maybe we have been in a situation where we've managed a mental health emergency for someone we care about. And so this may bring up some stuff, both in the work that we do, but also personally. And so I always just encourage everyone, whenever we're talking about these sorts of things, to please make sure you're taking care of yourself, make sure that you're doing some kind things for yourself, stay hydrated, drink, eat food that's good for you, snuggle up with the cat or the dog, whatever it takes to make sure that you're taking care of yourself as we discuss this information. So the good news is that changing what we do matters. I always like to start with good stuff. I think that responding to trauma and to mental health challenges and to have these kind of conversations about systemic reform, this is incredibly important. The good news is that the neuroscience is really clear that when we change how we interact regarding not just emergency, but also thinking about prevention, right? Preventing emergency. It's great that we're talking about 988 and how to intervene in crisis and some different options with that. But ultimately, our goal is also to destigmatize talking about these things, to create systemic reform, to think through what new options might be in the space. And I think that that's really exciting because we know that that matters and that that's actually going to save lives. And it's going to be a situation where we can prevent an escalation to crisis. And so 988 is intended to be this kind of new safety net concept, but it also is driving other conversations that are much more geared toward trauma-informed systems and thinking about institutional responses and preventive responses, which I think is really exciting. Christina, I'm interested. I would love to have a side chat with you about what that experience was like. I think that there are lots of different ways that folks are going to be interested in getting some feedback about that. I have a SAMHSA link for you at the end of this PowerPoint, and it may be that there's a way to offer feedback there. I'm interested in hearing that. The thing we'll talk in just a minute about how it actually rolls out. And so it may be that you also could find a connector to offer feedback to your local infrastructure, because that's actually the first point of contact when someone calls 988 is the local infrastructure. It's not intended to go all the way to the national number again. So first of all, I think we all know this, but it bears repeating. We know that mental health emergencies are on the rise. We know that we've got some really vulnerable populations, particularly for thinking about, death by suicide. We're talking here today about overdose, but, we also know that we have other types of mental health emergencies where 988 might be utilized. And there are some very critical pressure points going on in the country right now. You'll see massive changes in emergency room visits with suicide attempts for youth. That's gone up significantly month to month right now, with certain populations of young people being most vulnerable. We also know that we've got really very serious issues with suicidality in elderly populations. A lot of the theory is that that is connected to social isolation and a lot of the secondary impacts of the pandemic. We also know that the fastest growing demographic for death by suicide in the country is actually elementary school children. And so this is an interesting conversation when we think about youth engagement and outreach and letting young people know that this is an option for them. Are we prepared, or are we thinking about what if that's an 8-year-old on the other end of the line? Who's going to take that? And so there's a lot to consider, but we know absolutely that mental health emergencies and crisis are on the rise. So why not 911? As Merlene mentioned, my team and we train lots and lots of people in mental health first aid certification. Last year, we trained about 2,500 people, and I trained almost 8,000 in trauma-informed practice last year. And in that experience of training thousands of people in mental health first aid, you get to that point in the training where, in the section about suicide, and the slide says call 911. And we have always known as providers that that's not going to be an option for a lot of the people that we work with. We know that there are really serious data points around use of excessive force. The police response, we know that when it comes to overdose, lots and lots of folks are, they don't want to call 911 because what are the potential repercussions for that? When public safety gets my information or knows where I live or is asking me, where did you get that substance? So there's lots of reasons why people don't want to call 911 and don't want to interact with police. There's also, some real deep conversations in utilizers of these systems around involuntary treatment, being on a psychiatric hold. Aren't there other options? Why can't we do something differently, right? So there's this sort of growing community-based conversation about involuntary treatment in and of itself. And we know that stigma and historical traumatization really are significant and very real barriers to people feeling safe and calling 911. What if I am in a family with mixed documentation status? Am I going to feel safe calling police to manage a mental health emergency? What if my, what if my family has a lived experience and history with police? What if that's been intergenerational? What if I live in a community where we don't feel safe if we call 911? So it's not just like, I think when we say stigma, sometimes, that gets diminished as a conversation. I like to put that back into conversation and say, actually, this is also driven by historical traumatization. And that's very, very real. It's epigenetic, it's in the DNA, and that's legit, right? There are biological responses that people are going to have to some of these perceived threats and real threats. So it's important for us to recognize that. We know that this is disproportionately affecting certain communities more than others. And so there, lots and lots of conversations about what are the alternatives. And that's really why 988 is here, is because it was like, there's got to be a better option than 911. I see in the Q&A, so Jennifer, the name of my organization is Cypress Resilience Project. And maybe it's possible, someone from CHLP, maybe you could put the link or something in the Q&A, that's fine with me. And yeah, so there are a lot of, I see in the Q&A also, there's a conversation about social media sort of pushing back on 988, and we'll get to that in just a minute, because that is a concern for a lot of people, absolutely. And I love everybody. Thank you so much for putting where you're from in the chat. I've been watching you like, oh, it's really, you're making me want to travel though, because I'm seeing a lot of really amazing places that I miss going to. So I've been in my little corner here teaching and teaching. So I'm excited to see where you're all coming from. So, so what is 988? Like, what does it actually do? Basically, it just bypasses the 10-digit national suicide prevention number. That's basically, instead of having to remember 10 digits, people can remember 8. And it's not a new service per se. It's just a streamlining of the service. The concept being easier to remember, something that lots of folks can, kind of keep in their head the same way when you were, you learned 911, you learned 988. And so it doesn't do anything in particular that's like revolutionary, right? It's just connecting people to crisis counselors. What it does though, is it directly links you to a local resource. That's its intention. The intention is to basically like connect you to a local hotline with trained people. And then you are, talking to someone who's a crisis counselor, and that person can make a determination about whether or not a different kind of wellness check is required. They are trained in, for example, creation of safety plans. So if I'm feeling unsafe, maybe I can create a safety plan with the crisis counselor on the phone. But this is intended to be a local person, right? That I'm connecting to someone who is in my region, who knows the resources on the ground there. That's its intention. The backup, let's imagine I call and it's busy, or I'm on hold or whatever. The intention then is that the backlog goes to the national number. And so that's important, because back in the day, like, you would get this national number and then it was the opposite direction. You get someone nationally and then they're trying to connect you to local services. This is intended to be first a local response, a local connection, who understands where you are, your region, what resources are there or not. And then the backup plan, the plan B, is that then you talk to someone at the national level. So and that person is making the determination about whether or not you need some other type of service. Do you need a wellness check? Who might do that in your region? There's lots of growing options right now about what that means. It may mean a police response, but in a lot of places, it doesn't necessarily mean a police response. And so we'll talk about that in just a minute. It says, what are some techniques to increase buy-in, as our 988 is not currently willing to be a resource for overdose prevention and response? Yeah, Heather, like it's very, I think the issue of overdose is something that we will talk about in just a minute. I think that there's a big conversation here, right? Like, is 988 the right number to call for overdose? Because I need transport to the hospital. I might need naloxone, right? Like, is 988 the right number to use? And so I think that there is some concern out there. Does calling 988 in the instance of overdose actually delay the action that needs to be taken? So for example, like, I need this person to go to the hospital. Am I adding an extra step in here if I call 988, right? Yeah, and I see, Heather, you're saying in the chat that you feel it would be dangerous. I think there is concern there. And it's a growing conversation, believe me, about what, when do we use this? When don't we use it? How do we educate people about that? I want to be really, really clear. This thing just went live July 16, right? So we have like a month of it being active, and we're going to learn a lot really quickly about what is working and what isn't working. We are already seeing pushback in a lot of different areas and concerns, totally legitimate. I think that we have to sort of analyze what are those gaps in service, what are those challenges, and then sort of repair and hone best practices from there. It is not going to be the number to use for everything, but neither was 911, right? And so this is an balancing act, and we're sort of in this process of just implementing and seeing what's going on. So what are some of these potential concerns? You guys are already mentioning some, and I think it may be, in alignment with some of the things I've outlined for you here in the PowerPoint. Some of the potential concerns, first and foremost, do we have enough people to answer the phone? The expectation, the projections right now is that the sort of destigmatizing piece of 988, the fact that just the facticity of it not being 911, they are projecting double the number of calls. There are many, many regions in the country that are not prepared for that. Do we have enough multilingual, multicultural crisis counselors on the other end of the phone? I do workforce with my other hat, right? And I can tell you right now, no, we don't have enough people, and let alone people who speak multiple languages or come from a particularly vulnerable community. So it is going to be critical that in alignment with the implementation of 988, we are also having very real conversations about workforce. How to make deep and significant investments in making sure we have the multilingual, multicultural workforce that we need to staff these phones. Do people know about it? We showed in the poll that some of you are like, hey, I'm new to this. And others are like, oh, I know all about it. Some people are like, well, I've heard about it, but I need to learn more. We know that there's a lot of outreach that we're going to have to do in community. And we also know that, oh my gosh, like if there's a lot of stigma with 911, it doesn't necessarily mean automatically that people will not feel that with 988. And so really important to be having the conversation about what kind of outreach do we need to do in our community? Who needs to know about this number? Who doesn't need to know about this number? Or do we have alternatives? And I think if you are in your region and you're saying, you know what, there are gaps in 988 and we may not always recommend its usage, then what are we going to do differently? Right? Like if it's not going to be 988, then I would challenge and say, okay, what conversation do we need to have in our region that gives us other options? When we teach mental health first aid, we are constantly talking about having lots of tools in the toolkit. We don't want to be reliant on one thing alone. And some of that also is because there may be pushback with that person. I always say to people, look, you want to have 2 or 3 options of different things that people can use and can feel comfortable with, because you're at a certain point, you're needing to engage that person in coming up with a solution to this crisis. Right. And when you do that, if you just come at them with one option only, you're not protecting the autonomy and the dignity of that person. They need to have some choices. Now, I always say we don't want to have a choice about whether or not we connect to some support. We are going to do that, but let's talk about what our options are. Would you like this number or this number? And so I think 988 is great that it's bypassing that 10-digit number. It's easier to remember all of that, but it shouldn't be the only tool you have in your toolkit. Right. So how do we educate people about what's available? I think that's a really important piece. And do we have enough resources in high need areas, right? So crisis hotspots, those can be easily mapped. Public health is absolutely mapping those. But we also need to think about, like, what are the resources for our rural neighbors? What's going to be useful or not in an urban area, in a suburban area, all those places where you're all coming from. So it's really, really important that we be thinking about what are the resources on the ground. And some regions are resource rich and others aren't, and we know that. That's another reason to consider that workforce concern. So I hear, that I'm seeing in the Q&A that there's lots of controversy about 988, 911. There's concerns about using it for overdose. I know that I see, Glenn, you're saying some vendors are willing to walk through the, naloxone intervention. I think that's amazing. It definitely is something, obviously, that you need to consider with, getting naloxone out there, right? Along with then knowing your vendor can walk through. You can walk me through naloxone, but if I don't have it in my bag, it's not really useful, right? So we've got to make sure that we know that there are going to be maybe some folks on that line that can walk someone through administering naloxone and overdose, but do they have it with them, right? So, and Glenn, yeah, so SAMHSA has been doing a national awareness campaign. It just may not feel like it. So they've been out there and trotting it out, and I'll show some of that stuff in a minute. But yeah, it's taking a while, and I think a lot of people are still learning about 988. Certainly in the work that we do, it's something that we're constantly educating people about, which is why we're here today. So what, when you're thinking about these things, what are some of these concerns? One of the most important things is thinking about that, that I think for me, the number one concern I've heard, and someone said it in the chat earlier, has been about what's the response going to be if that person, that crisis counselor on the other end of the phone, decides that a wellness check is required, right? Everybody's very concerned about the fact, like, hey, I called 988 and you still sent the cops, right? Like, what does that do for communities of color? What does it do for folks who may have had different interactions? You saw people with disability diagnoses, people with mental health diagnoses, they've experienced excessive force 16 times the rate of other folks. What if I'm one of those people? You told me 988 would be better and the police still showed up. We know in some regions that if a wellness check is required, that may include involuntary treatment, meaning we go to an acute care center and it's a 72-hour cycle. What if that person's been system involved before? I didn't want that. I wanted a safe place to create a safety plan. I wanted to be able to talk. So I think a lot of people, this seems to be the sort of biggest concern, is like, I called 988, I thought it would be different, and it turns out it was just the same. I think that there are a couple of things to sort of that have been out there in social media that we can sort of say, okay, like, let's think about this too and put it in context. Number one is the data sort of proves that it's a very low percentage of people who require an emergency response. Most of the people that call the National Prevention Hotline feel better talking to the crisis counselor. They're able to draft a safety plan. They're able to talk about people that are in their circle of support. They can speak to that person about reasons that they want to survive. They feel better thinking about, what, I can reach out to this person or that person. There's a lot of things that go into making a safety plan. If any of you are CIT certified, our team all is, so crisis intervention training certified, there's a lot of things that go into de-escalating that situation, calming it all down, making the person feel connected. Sometimes they can even schedule follow-ups, like, let's talk again tomorrow, and make sure that you're still feeling safe. And so we know that's actually a relatively small percentage of those calls escalate to the point where there's no conversation here other than, we just need to make sure that you're safe. right? And so that I think is important for us to know. It's not the majority of the calls. The majority of the calls, people are going to feel better. We know that 988 can't geolocate people. That has been a huge thing on the internet, in social media, that the second that you call, they're going to be able to know where you are. That it does not have that capacity. You would have to reveal to the 988 crisis counselor where you are. It can't geolocate you. And we know that there are lots of other options. I just have one here, just warm lines, where the situation may not be a crisis, right? And so you're going to see a lot more of these warm lines where it's just like, I'm feeling a lot of stress. I am really struggling right now, and I need to talk to somebody. A lot of the warm lines are staffed by people with lived experience. And so it's also that sort of connection to someone who gets it, right? Maybe it doesn't feel as like I'm connecting to a system of care. I'm connecting to a person who has maybe walked in my shoes, feels what I'm feeling, understands it, gets it. And I can de-stress and de-escalate the situation just in connecting with another human being. And so warm lines, we're expecting that those warm line numbers are going to go up significantly as well. Not every situation, even of thoughts of suicide, is an emergency. Lots and lots of people have thoughts of suicide, and it doesn't escalate to a 72-hour psychiatric hold. Many of us have probably supported people who have had thoughts of suicide, but the creation of connection, talking to someone with the proper training, the creation of a safety plan, it definitely can help most of the time. And so that's an important thing for us to keep in mind. Now, it doesn't take away from needing to have strong plans for what are we going to do with that 2%, particularly if we see a doubling in the number of calls, right? It is completely possible. And we know that crisis is being reached. People are reaching levels of acuity at much faster rates. You've all seen it in the work that you do, I'm sure. And you've probably just seen it at the grocery store. People are escalating and situations are getting out of control pretty quickly. So it is important that we have, again, a lot of different options, and warm lines are one of those. So I see, Gloria, how can we find warm lines? So you'll be able to access these slides after the training, and that link is live. Mental Health America has a search engine where you can search all these different warm lines, and those can be very effective connectors for people who are feeling stressed, maybe managing a mental health issue, but it doesn't necessarily mean that it's all the way to crisis. I find them very useful in referring folks to those. So what is being done to address some of these concerns? You are seeing lots and lots of money. That's always the first thing, right? Follow the money. The bulk of the first bit of money was really to try to support the actual hotlines themselves, the regional hotlines. It was a recognition of like, you know what, we don't have enough crisis counseling infrastructure in all of these regions. We need to bolster that. We need to add more bodies to answer the phone. Again, with this expectation, we're going to see an increase in the number of calls. We know that certain states are getting direct funding. Here in my state of California right now, we saw direct funding come to the state of California from the federal government. It's going directly into county systems and regional responses. We know that there are also more regional sort of efforts being made to coordinate non-police response. So for example, mobile mental health units. Mobile mental health units very often contain a social worker, maybe a paramedic or an EMT, maybe a peer specialist. These are different types of professionals that can respond. The ones that I have seen include food and water and clothing, and a minivan drives up instead of a squad car, and a social worker and a peer specialist get out, and their job is to assess the situation and make a determination. It's to de-escalate the situation, talk to the person, communicate, connect with them. And there are incredibly great data points and research being done on the effectiveness of mobile mental health units. And so there you're seeing 988 and this question of like, who responds, driving conversations about we need to have other options, safer options than squad cars. And so mobile mental health units are an amazing response for that. You are seeing a lot of advocacy and establishment of non-acute care assessment, meaning you don't need to necessarily go to the county hospital. You don't necessarily need to go to the emergency room. These safe houses are residential, agencies, and you are still monitored. You're still assessed. It's still the sort of safe place for you to go through that process, but much less traumatizing. And so you're going to see continued conversation in regions about, can we have another option, a less traumatizing option than just putting someone in an acute care setting? Oftentimes, when people are on psychiatric holds, that's incredibly traumatizing for them. Oftentimes, they may be restrained. There's no visitors or connection with family. Your cell phone's taken away. There's a lot that happens sometimes in those settings. And people, if they've gone through that before, don't want to do it again. And so we don't ever want those folks, because they've been through something traumatic, to not reach out for help when they need it. And so these establishments of different options for what is it like to be psychologically assessed, I think are really important. We know that there's more focus on safety planning, and lots of different kinds of conversations on these hotlines now that are about safety planning. They're asking different types of questions. It's not just an immediate, hey, let's go to calling, for a police response. There's going to be constant conversation about de-escalation, CIT training, safety plan training, and 988 is going to drive a lot of that, which is a good thing. We're seeing concurrent investments in the workforce. Again, everybody knows we don't have enough multilingual, multicultural providers that are able to fully respond to what we're seeing on the ground. And so there are already, but there will remain very significant investments in the workforce. You're going to see loan repayment, scholarship, all different kinds of pipeline investments. And then mental health first aid is becoming this first practice, right? So we consult a lot with different organizations and agencies who are interested in mental health first aid. So for example, we just worked with a school district. This school district wanted to address some of the thoughts of suicide and self-harming behaviors, including substance use in their student populations. And we worked with them, and now they're doing teen mental health first aid, which means every single sophomore in that entire school district is getting teen mental health first aid certified. One of the qualifiers for teen mental health first aid is that 20% or more of all the adults must be youth mental health first aid certified. So you can see an institutional response around mental health first aid, which means hopefully we're not getting to crisis as often because people have eyes on us. Yeah, it is great news, Jackie. It's awesome. The National Council for Mental Wellbeing is currently piloting a child mental health first aid, which is for adults supporting children, again, because of that issue in the rising suicide rate for elementary school. And so soon you're going to see lots more people certified in mental health first aid. And the whole point of mental health first aid is avoiding crisis and how to actually handle crisis without just having that knee-jerk reaction to call 911. So when we teach mental health first aid, we're giving lots and lots of choices and options. And I think it's really important that we are able to, again, sort of broaden people's ideas of the tools they can have in their toolkit to support folks. But we know that mental health first aid, like this is like one of those things, like everybody should have it. Everybody should be certified in mental health first aid because it's going to help with interpersonal communication skills. How do I start a conversation with someone? But it's also, how do I safely navigate a crisis and keep everyone whole in that process? And this isn't perfect. right? This is not going to be perfect by any stretch of the imagination. We know that there is a lot of work, even with those investments, even with those acknowledgements, there's still a lot going on. I think we absolutely have to continue to assess the settings in which treatment happens. So what, again, to that point of like, hey, not everyone who has been system involved before is going to feel comfortable going through that again if we keep it the same. We've got to be thinking about changing the model and really challenging ourselves with thinking through what works, what doesn't work, what could we do differently. Absolutely, we need to know who's going to staff all those mobile mental health units. If already we're seeing, well, gosh, we already need more crisis counselors and like all of that sort of thing, like, we want mobile mental health units. Who's going to be in there? I know if we all sat down and we started to talk about your behavioral health workforce, I know there are deep stressors there. I also, one of my most requested trainings right now at Cypress for professionals is burnout, toxic stress and burnout. And so it really is important because, we are having a difficult enough time retaining the workforce that we already have, right? And then on top of it, we need more multilingual, multicultural people. And so this concept of the workforce, who's going to actually do this? This is a real significant stressor to 988 being effective, to mobile mental health units being effective. We are going to have to really invest in the workforce in order to make that a safe option for folks. How does this all align with red flag laws? There's lots of conversation to have here. Red flag laws in many states are, you can request a wellness check and someone may have weapons on site. And in some regions, the police can confiscate that weapon, hold the weapons. The person goes through the psychological assessment and then has to even sometimes go before a judge to retrieve their weapons again. And so this is a real conversation with all of the dialogue also about guns, with mass shootings and some of the things that we've seen there. It is completely possible we will see more red flag laws. And sort of like, regardless of how you feel about that, the interaction with 988 going, it's a national number, right? This will be a significant issue because you also in some of these states have laws that say, I can come and take your weapons if I think that you may hurt yourself or other people. And so there's going to be a lot of conversation going on, like, how does 988 interact with that? Are you going to see increases in those red flag laws as a sort of reaction to mass shootings? And so that's a whole other kind of conversation. And the data, red flag laws, it's, a lot of them are still relatively new. So it's not like we have a ton of data over, how effective are they or not. We have some, but not nearly the longitudinal data that you'd want to have in thinking about, like, how do we really keep folks safe? Yeah, Taylor, I see. Yeah, exactly. Working with veterans, like, there are lots and lots of different ways that, maybe that increases safety, maybe it doesn't, but like 988, if I found out, let's say that I live in a red flag state and I call 988 thinking that, that's a destigmatized option for me. And then, that crisis counselor, finds out that I have weapons on site and determines I need a wellness check. Now my guns are confiscated. There's going to be pushback on that in a lot of different regions. And so I think there's a lot going on there. None of it is figured out yet, but just be aware, especially if you're in a region where you do know that you've got red flag laws. And then, of course, for our concern today, how does this relate to overdose? And is there a delay? And a lot of people who work in the overdose prevention space are saying, actually, I'm really concerned about this because we need transport to a hospital. How are we going to make sure that we have that, and that we don't have this extra step? I think that, again, what I would say about that is we always want to make sure that we have options, that we have a lot of different choices about how to support someone. We're not relying on one tool only. But this is a place for your overdose prevention coalitions to get involved, right? Do you know what your regional response is? Are you connected in partnership? Have you included in your coalition the people who are running the 988 response in your region? Really important that you know who the players are, what they're doing, what the gaps are, and that you have a voice at that table if you're concerned about how this may impact people who experience overdose. And what if it's not going to be 988, then what's it going to be? So, we know obviously that there are, all different ways in which this impacts your work, some of them positive and some in challenging ways. I think, first of all, it does offer an opportunity. It gives you another tool of communication, education, and outreach for the communities, right? And so that absolutely, you can use 988 and a lot of the technical assistance I provide opioid coalitions, this has come up, which is like, oh, wow, we're going to translate this, we're going to make this known, and we're going to leverage it to have other conversations about the other services we're providing, maybe things like naloxone training, et cetera. We've got vending machines over here. We want to do outreach around 988 and let people know that we've got vending machines. That sort of thing, I think, is a way to leverage 988. The other thing is that 988 is going to identify gaps, including what's not being considered and who's not at the table. If you work with a particularly high need population and you can see that 988 is not going to be an option for them, important that you're at the table. I'm seeing lots of coalitions diving into the 988 conversation so that they can show those gaps to those public safety folks who are engaged in the 988 conversation. We know that there will be more community-based strategies. I think this is great. I think it's amazing to have 988 driving a conversation about mobile mental health units. I think it's fantastic to see community-based solutions. How can we get more mental health first aid training? Regular folks, does the bus driver, the librarian, the teacher, do they know what to do to prevent an escalation to crisis? I think that's all good stuff, and it's community-based. And why is that important? Well, if we don't have enough multilingual, multicultural people, professionals to handle this level of need, we need people who are already in the community, that already speak the language, that already know what's up, that already have the culture framework. They already are going to know what resources would work with this person I'm supporting and what won't, in a way that someone on a crisis counseling hotline may or may not. And so the resources and focus on community-based response, I think, is just one of the very best things here, because again, the more people that are having this conversation, destigmatizing it, they have lots of tools in their toolkit, then we can avoid the crisis in the first place. And that's going to bring those numbers down around interaction with squad cars anyway. Workforce investments, those are always good. And then obviously destigmatizing accessing care earlier rather than later is ultimately what this is intended to do. And when we're talking about overdose prevention, that's always the goal anyway, right? Like that's the goal, is to prevent the overdose when we can. If we can't, then we want training on the ground on how to handle that effectively, keeping everyone safe and whole in the process. And so destigmatizing accessing care, whatever that means, including harm reduction strategies, 988 can be a door into that. I see in the a couple of questions here in the chat. Do you know if we'll have a training of the trainers for 988? So Celia, that's a really good question. I'm guessing that's probably going to be based on region and regional response. Some regions are likely going to, be reaching out to community and making sure that people are trained. Other regions, I think it's a region by region kind of thing. And Paul, your question about will 988 operators direct people to warm lines if they determine the caller is not an emergency? I think what the intention is that the crisis counselor on the phone, who again, first one should be regional local person, is creating the safety plan. That may or may not include referring them to warm lines. But basically that person is deciding with that, caller, what are the things that we can put in place. And maybe warm lines are one of the tools in the toolkit. I like them because it's a place for people to go when they're not at emergency levels of crisis. They just need someone to talk to. And so I think that they're a good tool. I'm guessing that some crisis counselors will definitely use them in the toolkit. Yes, anonymous attendee, like, why did they launch it? That's a great question. Some of us had that same question when it went live, like, we're not ready, like, how's this gonna work? And so I think that's a legitimate concern. And one of the good things, I guess, about it launching is, like, here we are all talking about it, right? It's 314 people here today talking about this. So that's a good thing. It's driving a lot of conversations. It is not the only investment that's being made. It was designed to try to address an immediate concern, which is when we call 911, too often a squad car arrives. Could we do it differently? And in that way, 988 is a good thing. So I think that, it's like this, right? Like, yeah, you got to launch sometime, and no, we're not totally ready. So Kristen, what they did is, but usually only if you were in crisis. So if you called the national number before, and then you got the crisis counselor, you were talking to that person, and they felt like, wow, Kristen really needs a wellness check. I don't think she's doing very well. Then they would locate your local resources. But again, too often that was a squad car. Right. And so you've got all these different horror stories of escalating situations. I called the national number. I thought I was okay doing that. And now I got the police at my door. And I do think that's one of the greatest flaws, is if we can't figure out how to get mobile mental health units as a response, that's going to be a consistent problem for people. That will undermine the credibility of the resource, because then you've got, exactly the response I was hoping to avoid is at my front door. That's going to escalate situations again, particularly for communities that have historical traumatization. I also have a question here about how are the 988 teams assigned in each county? That's a really great question. I am so sorry to tell you that it's all over the map. There is no consistency, even state by state. It's just all regionalized. That is good insofar as those local resources know the people on the ground, they get the community, like that's part's good. It's not good because we don't have any cohesive strategy, even state by state. You have to do some digging, I'm afraid, and try to find out who's handling this. In some regions, I've seen it's fire. Some regions, I've seen it's public health. Some regions, it's the county behavioral health system. It really differs from place to place, and I'm sorry to have to tell you that. But I think you need to do some digging to find out what's up in your local community. The other thing I just want to sort of think about and leave us with it are some promising practices, some things that I'm seeing on the ground with the implementation of 988 and the ways in which different folks are getting ready. Certainly, this is increasing the pool of people with lived experience who are responding to crisis. I have worked with lots of different communities as a technical advisor, and there's a lot of really great out-of-box thinking about who can be in that mobile mental health unit. Does it always have to be like a licensed clinician? Is that always the right person? And particularly for certain communities, right? So I was just working with a group of formerly incarcerated folks who had for years and years been doing healing circles with their incarcerated peers. They've been leading the healing circles. They had been trained in trauma-informed practice. They had been certified in mental health first aid. They had all of this amazing skill set in de-escalation. They knew the population really well, and they were creating their own mobile response for their own reentry population. I thought that was genius. That was something that we never would have seen, 5 years ago. It was like, wow, this is a mobile response. We're reaching out to our community, and you know us, and we get you. And so I think there's a lot of really great stuff happening around thinking about, like, who are the right people to respond in some very high need situations. Maybe that's the work that you guys do. Maybe it's substance use counselors, or it's peer specialists. It's people with the lived experience going out to address the situation on the ground, to talk to that person that has relatable experience. One of the things I would caution is that then what do you do to help that workforce when they come home, right? Because if you have people with lived experience and you send them out and they're going to be exposed to crisis and emergency that may be bringing stuff up for them, and they may experience vicarious traumatization, secondary trauma. And so you want to make sure that if you're going to do this, you have the systems and conditions in place to manage toxic stress, vicarious traumatization, and burnout, because otherwise you're just going to go through these people, and that won't be fair. And a lot of the work that I do with overdose coalitions, that certainly is the case, right? I spend a lot of time talking about toxic stress management, vicarious trauma, because we're very purposefully choosing people who have lived experience to do the work, and that's going to bring stuff up for them. And we don't want to burn them out, and we don't want to re-traumatize ever. So if the workforce are folks who have lived experience, how are we going to support them to make sure that they can do their job and do it safely? We know that the residential facilities for assessment, those are popping up all over, those safe houses as an alternative. I think you're going to see increased in those. I think that they're a really promising practice moving forward. It gives, again, another option. I'm seeing lots of cross-sector collaborations that wouldn't have worked together on crisis response in the past. A lot of things in mental and behavioral health are siloed. The trauma people are over here, the mental health people are over here, the substance use people are over here, the grief people are over here, but that's not how a person experiences their own life. When you are experiencing trauma, it comes with grief. It may come with a secondary mental health diagnosis. It may come then with self-medicating behaviors. It's all intertwined in a person. And so I think that these cross-sector collaborations that are trying to figure out what are the right responses for our community are really important. And I'm seeing people coming to tables before that haven't done that, particularly around crisis response. Absolutely, we're seeing more resources for mental health first aid and crisis intervention trainings, lots of different kinds of people getting that training. I think that's really important, as I've said. And then, of course, workforce development, huge investments in making sure that, that workforce knows what the implications are of the rollout of 988. What do we really need on the ground? What can we do to invest? Of course, behavioral health workforce investment is already top of mind for everyone, but it also, 988 is going to drive more and more of that. I told you that I would make sure that you have some other tools and things, to make sure that you are looking at what SAMHSA is doing. And so we've got this a link here for you. Again, you can access that when you access the slides. It's got different toolkits, data you can use, some outreach materials, etc. if you're interested in getting more involved in letting folks in your community know about the rollout of 988. So that is my email address in case anyone needs it. Please feel free to reach out. I'm always happy to chat about these things. I see that Ari's been putting lots of links in the chat. Thank you for that. I know that we've got this quick survey that's in the chat box. That would be fantastic if you could let us know how we can continue to improve. I want to make sure to review these, the Q&A just a second and make sure that we've got that. Stephanie, I see that the rollout kits, yeah, so you can absolutely look at some of the SAMHSA toolkits. Some of them are okay. You might want to take some of what the material is there and really customize it to your audience, because remember, outreach and communication about these things really needs to be culturally sensitive, and making sure that you're rolling any kind of communication or outreach about mental health in a way that feels like it'll resonate with your audience in an effective way. But SAMHSA's got some places to start for that. And let's see, I see, is 988 a recommended resource when a person's experiencing substance use, mental health? So that's, again, you know, a really good question. I think the interaction with 988 and substance use and overdose is still a big question mark. Is this a helpful resource or not? Again, I would just kind of reiterate, I think that it's important to have more than one tool in the toolkit. 988 is one tool. It is not intended to take away all of the other really wonderful tools that we might have, things like warm lines, mobile mental health units. Also, remember, there's amazing crisis hotlines out there. I think of like the Trevor Project. If I'm a young person and I identify maybe gender non-conforming or LGBTQ+, like maybe the Trevor Project crisis line is a better option for me. And so you always want to make sure that you've got lots of choices for people. And Heather, yeah, so I see that you've got the CIT and removing police, and yeah, so CIT has been typically used in public safety. You're absolutely right. And we're starting to see CIT being used with educators, public health officials, et cetera. So I think there's an expansion of what CIT might mean. So I know we're at time and I want to be respectful of that. Just a reminder that on September 7, there's another upcoming webinar, Opioid Settlement Dollars, a breakdown of the process and what it means for your work in overdose prevention. Everybody needs to know where those dollars are going. So I highly recommend you making some time to find that out. And then of course, always feel free to reach out to the National Overdose Prevention Network at nopen.org. They've got all different kinds of resources for you, including the updated list of new trainings and webinars. So make sure to do that. And I will make sure that I pop in the chat my email address in case you missed that before. Please feel free to reach out. Thank you everyone for your time.